as your sign-in code was incorrect, the correct ID is 213010. Okay? Thank you.
Thank you very much. As she was saying, my name is Anthony Hammonds, and I appreciate y'all having me come today. I'll be honest with you, when I first heard about this, I thought we were going to be doing kind of an impromptu roundtable discussion on hormones and just compounding in general as it related to women's health. And then I found out, no, we got to have a kind of a formal presentation. So please bear with me. There may be a slide or two that's out of place here. Kind of threw this together really quickly. It's a presentation that is a couple years old, but it's still very relevant, comparing what is needed in women's health and what we see prescribed for women's health today. And so my focus is primarily going to be on natural hormone therapy and also some pain management, fibromyalgia, that type of thing. We're going to talk about that a little bit and what some of the alternatives are for that, and how those can be beneficial than just regular traditional medications. Disclaimer. Hormone replacement therapy, really the goal of that is to kind of restore the hormone levels to the normal levels that when we were younger, and just to provide benefits to the whole entire system, whether it's premenopausal, menopausal, or postmenopausal. And each individual person is taking a look, and we kind of get a panel for those folks. You know, sit down, we talk with them when they come in, and say, hey, you know, what is your symptoms? Where are you at in your life cycle? So everything on a hormone replacement therapy basis is individualized to the patient's needs. It's just not a one drug fits all plan, and that's the difference of hormone replacement therapy. And we'll kind of talk about some examples and kind of talk about the benefits going forward. The need, synthetic hormones can cause unwanted side effects and health risk. So a lot of patients are just asking for the natural today. And again, like I was just saying, a one-size-fits-all product usually just does not work for everyone. The dosage forms that are typically used in both pain management and hormone replacement therapy is transdermal gels, capsules, troches, and suppositories. Now, there's a lot of other dosage forms that are out there that we commonly use, but this is the typical ones as far as these two go. We can also do lollipops in compounding. We can do lollipops, gummy bears. We can do mini troches. Course injectables, we can do those, but these are typically what we see when it comes to these two areas. This whole debate over traditional medication, estradiol today, of course, Prempro and those are pretty much gone as of today after the Women's Health Initiative study came out. So there's a lot of science, opinion, marketing. You know, what do we do? Where do we go from here? And this has been kind of an ongoing debate over the last few years, over the several years, because that study was done in the early 2000s and was actually stopped short after about 5 years because of the disadvantages and the side effects that Prempro and Premarin were causing. Here's kind of where we start. The study kind of laid out, you know, what Prempro and Premarin, what is, you know, stroke is increased, blood clots was shown to be increased by those. Heart attacks was increased by Prempro, breast cancer increased by Prempro. You know, very few times do you see something that's, you know, either neutral or decreased. But that was basically the whole basis behind the Women's Health Initiative study. This is kind of what it was shown to be the results. Had all kinds of medical societies and the FDA coming out stating that there's little or no evidence to support the claim that bioidentical hormones are safe or more effective than synthetic hormone replacement therapy. Wyeth really, at the time, there was lawsuits filed. know, a lot of compounders. Compounding pharmacy is a very big lobbying group, okay? They're very, very active. Compounding pharmacy is typically an independent niche, and independent pharmacists, very, very proactive, and especially compounders when they started doing this hormone replacement therapy. So Wyeth at the time, there was a lot of lawsuits that went out, and I'll show you one of the things that kind of prompted that lawsuit here in just a minute. But you know, they were like, no, I mean, you can't do that. You can't say that a natural product is, and I think what they were getting at is they were saying that, oh, you can't state that a natural product is any more efficacious or any more safer than what we had on the market. That was the whole thing. And so there was lawsuits filed. There was some chemicals there was one hormone chemical, E3, estriol, that was actually pulled off the shelf at the time. We'll talk a little bit about that in the coming slides and kind of show you the basis behind that. But basically, it led to a real big rift and a confusion of, well, where do we go? Do we just not do anything at all? That was kind of the basis for it. 2006, this American Society of Reproductive Medicine, basically down here says hormone therapy should be individualized for symptomatic women, which involved tailoring a regimen and dose to individual needs. Real small study that was put together, but shown that this was beneficial in doing it individualized patients. Here's what I was referring to. In 2008, the FDA ordered the stopping of compounding with estriol, stating it was an unapproved drug with unknown safety and effectiveness. This was basically acted on a citizen's petition organized by Wyeth at the time. Received about 70,000 or so letters concerning this. Come to find out, Wyeth was at the time trying to produce a drug that was based around estriol to help MS. Higher doses of estrogens has been shown to increase myelin production. Okay, and in MS, basically, that's one of the factors that the autoimmune system attacks is basically the myelin sheath. So Wyeth was trying to do this, and they had an ongoing study over in Europe, basically using estriol. What we have to keep in mind, though, estriol was not in Premarin, okay, or Prempro. You basically had estradiol, E2, estrone, E1, and equine, pregnant mare urine. Okay, that was basically what Prempro was in Premarin was the basis for. Estriol was nowhere in there. E3 and actually E3 is really the more protective estrogen when you look at the spread of estrogens. What compounding pharmacies at the time done, it kind of put them, because we were tailoring, we'll talk a little bit about this in a minute, we were tailoring estrogen therapy to be on a E3, E2, E1 basis, okay? And whether you were looking at a biest or a triest, 2 of the estrogens or 3 of the estrogens, most of the time folks back then were using all 3 estrogens, E3, E2, and E1. This really kind of threw the independent pharmacies that were doing this curveball. You know, what do you do? Most folks were doubling the amount of E2. They just taken, E3 was not available, so E2, they would just basically double the estradiol and leave the amount of estrone in it to kind of compensate and offset for this. In 2011, study came out, delaying therapy lowers breast cancer risk. The Journal of National Cancer Institute, wait 5 years after menopause to start hormone replacement therapy. You know, it's one of those things, you know, it's a double-edged sword. Danged if you do and danged if you don't, kind of. So, you know, the question still remains, you know, kind of what do you do, you know? Another study here with Kent Holtorf, the bioidentical hormone debate. Are bioidentical hormones E3 or E2, E3, and progesterone safer, more efficacious than commonly used synthetic versions and hormone replacement therapy? Study in 2009, 190 participants compared the effects of bioidentical and synthetic hormones. Greater satisfaction with progesterone compared to the synthetic progesterone. And we get this a lot, we get this a whole lot. Well, I'll go and talk about hormones or, so what about Prometrium? It's a product that's on the shelf today, supposed to be natural. Why not use that? Oral progesterone is very, very minimally absorbed, if not less than 10%. Okay, we see it dispensed sometimes today, but efficacious, probably not. Okay, the metabolites of progesterone can cause drowsiness as well. So there's some reasons why to kind of go toward the topical route, and we'll talk a little bit about that in just a minute. Progesterone associated with a diminished risk for breast cancer compared with synthetic progesterones. Synthetic progesterones have, again, a variety of negative cardiovascular effects which may be avoided with progesterone. This is kind of a slide just outlining those differences. You got progesterone here, the bioidentical, if you will. Then you got medroxyprogesterone acetate over here. As you can see the differences there, the antihypertensive effect, action can be safely used during preeclampsia over here. That one over there causes fluid retention and edema, therefore raising blood pressure possibility. Progesterone with estrogen enhances the beneficial effect of estrogen on exercise-induced myocardial ischemia in postmenopausal women. May reduce the risk of breast cancer, used to help maintain pregnancy. We see this one here. If someone has had a miscarriage, progesterone suppositories is usually the route of choice on that, and the drug form of choice, progesterone 100, 200 milligram suppositories. High risk pregnancies, we usually see that. Of course, medroxyprogesterone acetate is contraindicated in pregnancy. Transdermal administration will reduce the risk of blood clots versus the oral estrogens. Oral administration for those who do not respond to transdermal forms. And here's the other forms that sometimes we'll see the hormones put in, whether it's a drop, a troche injection, and an implant. You know, about 10 years ago, transdermal delivery system of a hormone, you wouldn't have seen that much out there, okay? Everything was basically done on a capsule or a drop, a mini troche or a troche. Today, the delivery systems have gotten so complex, and they've really came a long way. You can really get better absorption doing it topically on the thinner parts of the skin, the insides of the thighs and so forth, lower sides of the abdomen in this area here. You can really get some really good absorption. And they make bases today that are tailored. When we talk about fibromyalgia, we'll talk about some bases there that are actually geared to contain 40 or 50% of active drugs per the load. We have bases that are typically geared to be we got one that's called phyto base. And what it's geared to be is it's geared to be for estrogens and progesterones, for hormones. So the advancement of the bases has really led to a lot of transdermal formulations when it comes to hormone and pain therapies. again, just kind of reiterating, hormones typically better absorbed transdermally unless there is a reason why that cannot be done. It does avoid the first pass metabolism, reduces the risk of blood clots, and usually you can also give a decreased dose, 1/10 to 1/5 of a PO dose. Like I was saying earlier, the testosterone is pretty much out orally. I get a lot of looks sometimes and say, why would you use testosterone in a woman? Well, typically you're not going to at any high levels. 2 to 3 milligrams per dose is fine unless we're just completely testosterone depleted. But we're talking about increasing the libido and decreasing vaginal dryness. There is sometimes a need. But again, very, very low absorption, bioavailability when you do it orally. So again, transdermal is better. And like we just said a minute ago with progesterone, you're talking less than 10% orally. So again, transdermal would be the way to go. Just kind of what I was just referring to there, progesterone, testosterone, and estrogens. I mentioned a little bit earlier, we based the dosing of hormones on a biased or triased level, biased with the E3 and E2, E3, E2, and E1 here. Typically, you're going to see an 80-20 split. 80% estriol, 20% of the estradiol or 0.2 on a biased. There is other combinations, 50-50, okay? And we're typically seeing more of this today. The estrone has kind of just been taken out, okay? Estrone's considered to be the bad estrogen. If there's a bad estrogen, that's the one. So we're typically seeing this. Now, trias would be more of an 80-10-10 split, typically. 80 estriol, 80 estradiol, and 10, or excuse me, 80, 10, and 10. Dosing, we recommend to start very low and go slow as far as titrating upward. This is probably the biggest thing that we hear. I really don't know how to dose a natural hormone. Can you help me with that? And that's fine. We can. If that's what the patient wants and you're okay with that, feel free to pick up the phone and call a compounding pharmacist, and we can kind of help you through that based on what your all's professional opinion is and what you all think that the patient needs, based upon the symptoms, based upon what they're experiencing. We can kind of help you through this, but this is kind of how, a 0.1 to 0.5 milligram per day on the biased, whether you split the dose or it's just QD. Progesterone, 10 to 30 milligrams a day. Again, this is transdermally now. Testosterone, 0.25 to 2 milligrams a day. As you can see, it really kind of goes up hugely when you hit the oral. 200 milligrams is not uncommon, again, because you're not getting any bioavailability usually orally with that. The perimenopause cycle, mostly symptoms due to estrogen dominance, progesterone deficiency here. Of course, here's pretty much the symptoms, and most of them can be improved with progesterone alone, and we see that sometimes where there's no estrogens involved, and we just start a woman on progesterone alone. Here's the kind of the way we do the cycle on that. In the menopause, deficiency in estrogen and progesterone, but not always. Estrogen can be low to normal. Progesterone's almost always zero here. Dose continuous all 25 days of the month instead of the peri when we split it. Progesterone alone may improve the symptoms. If not, in adding the biased testosterone is where we usually go from there. The Commercially available hormones that are out there is the estradiol tablets, the gels, the patches. Again, Prometrium, as we discussed, which is considered to be a natural progesterone. Again, low bioavailability. Testosterone, not available in any kind of supplement really other than injectable. Disadvantages, dose adjustments are difficult, no transdermal progesterone available, no testosterone for women available, and cannot combine hormones to improve compliance. You know, believe it or not, this was kind of a huge deal. I mean, back when we just had the Premarin and Prempro, even though there was a lot of folks on it, the compliance and adherence was just, it was all over the board because, you know, I've been taking this hormone now for 2 months. I can't tell any difference. Matter of fact, I'm worse. I'm sweating. So it was kind of hard to tailor. So where do you begin with this? Kind of identify the patients who might benefit from this based on their symptoms, based on tried and failed other treatments, side effects to other treatments. Again, contact the compounding pharmacy if you need help on the dosing. I'll be glad to help in that. Speaks about the role of compounding pharmacists. Again, we can help with any kind of recommendations. Conclusion on the hormones: one size fits all does not typically work for hormones. Individualized treatment is a must for most women, and it'll give you a flexibility using the lowest effective dose for symptom control. Okay. We'll shift gears here just a minute and talk a little bit about pain management. And again, you know, there's a lot of compounds that we use for women and women's health, and but I really I wanted to kind of point out a couple things on pain management. We're seeing this really grow, and I think when you get out there and you start practicing and get in the clinics, you're going to see a lot of people talk about pain gels and how pain gels can be beneficial. So I really wanted to talk on that just a minute and kind of let you know how we can do those and what benefit they serve. Again, these are really popular right now. We probably do, I bet, 20 pain gels a week. Close to it, 10, 15, somewhere, sometimes 20. In pain management, again, similarly to the hormones, every patient is different and will respond to medications differently. Again, we cannot produce one medication that treats everybody. Okay, you know, 1 milligram of this strength, you know, a tramadol, a hydrocodone, you know, you kind of keep going up in dependency schedules and so forth, and it's just really hard to pinpoint how to take care of a patient. But that's what we try to do here. We try to customize these. You can do it by avoidance of dyes, preservatives, and fillers. You can make them into a liquid. You can adjust the dosage for them. A great thing with the gels is the avoidance of side effects. Okay, you can give somebody a gabapentin for neuropathy pain, and they say, "Well, I feel hungover in the morning. I can't function." But you can put gabapentin in a pain management gel, put it on the focal point of pain, and they're fine, and they get pain relief. So, and we'll talk about a little bit how we customize those in just a minute. But again, dosage form, medication not commercially available is what we're looking at. Some of these can be put in sustained release therapies. It's usually a cost-effective therapy, most of the pain gels. Now, let me say something about cost-effectiveness. There are some pharmacies out there that will charge $1,500 for a pain gel. Okay. Will insurance always pay that? No, they will not. Will some insurances pay that? Yes, they will. We've had some lately come in saying, "I went to such and such pharmacy and such charged me this for this pain management gel." You know, and you're like, goodness, you know, didn't need to mortgage your house. You know, so there are some people out there trying to take advantage of the system right now. but most of the time this is a very cost-effective therapy. Okay, I just want to throw that out because you may have heard that. That's not necessarily true. Depends on where you go. I get the question a lot, how do you know it works? What's the science behind it? Are you just putting a topical gel on and hoping it's absorbed? No, that's not the case. As I said, bases and delivery systems have came a long way. We basically put all, whether it's a hormone or whether it's a pain gel, it goes in one of these PLO type gels. There's two components to a PLO gel. There's what we call lipoil and pluronic. Okay, lipoil is the penetrant. That's what drives it down through the skin barrier and gets it to the source of the pain. The pluronic basically acts as a stabilizer and actually helps develop these micelles around the drug molecule, so it basically encapsulates that and then it drives it down better. It kind of encapsulates it and gets it. It's kind of the delivery system, if you will, where the lecithin phase or the lipoil, the lipid, that's actually the penetrant. Is there a whole lot of studies out there? No, there's not. Why is that? My opinion is that it's really kind of hard from individual to individual. It could be based on skin thickness, it could be based on the person, it could be based on a lot of different factors. Do they work? They work. Trust me. Heard too many people come back and say, I'd like to take a bath in it. It really makes me feel good. Okay? So they work. One of the first drugs that was ever done like this was promethazine PLO gel. Okay? That's kind of where the whole topical transdermal delivery system started. And it is very, very popular today. Just sidebar, just 1 minute. Why is it popular? Well, number one, if you're throwing up, you're pretty much going to have to tell little Johnny he's going to have a suppository. Little Johnny going to like a suppository? No. So basically, compounding pharmacies come up with a topical delivery system in that case. And we do a ton of promethazine PLO gel. It's dosed just like the normal dose would be, 12.5, 25 milligrams. And it just kind of escalated from there. Promethazine, pain gels, but that's kind of the science behind it. And yeah, it does work. There again, this basically just talking about the advanced type. This is a PCCA product, Lipoderm. There's depending on which company you go with. This is the drug delivery system. This is the base that I'm talking about here. This is a study here. Talked about Pentravan, which is a Fagron product. It's just a base, a delivery system. Talked about how it shows an increase in ketoprofen and testosterone. Testosterone was 1.7% higher in this PLO than the other standard PLOs that were on. Like I said, they've just continued to make advancements in these. That was from the International Journal of Pharmaceutical Compounding. Okay, where do we put it? Well, we put it on the place it hurts. Okay, the original injury site, the dermatome, if you will, trigger point of pain. That's where these are actually placed when you put a transdermal gel on. They're effective in arthritis, sports injuries, musculoskeletal pain, fibromyalgia, which we'll talk a little bit about, neuropathies, cancer pain, and physical therapy. Neuropathies is a big one. We can make up a cream for shingle therapy. We can put acyclovir in it, lidocaine in it, maybe some ketamine in it. Ketamine just pain reliever. So we can and put it on the focal point of pain. Really does a nice job in that one. Advantages of this type of delivery system, again, avoiding systemic side effects, bypasses the liver and kidneys, no GI irritation. That's a big one because we can put ketoprofen in here up to 20%. And not affect the GI tract. low plasma concentration for most drugs, again, therefore decreasing the side effects of drowsiness and so forth. Disadvantages, possible skin irritation. I'll be honest with you, I really have not heard many people have a skin irritation to these. They've really done a nice job with formulations on these. It must be applied to intact skin. Fibromyalgia. Symptoms include fatigue, sleep disturbances, pain, stiffness, depression, irritable bowel, headache, anxiety, urinary. Now, say it's about 2% of the general population. That's the latest percentage that I could find. But honestly, we see a lot of people present to us, to the pharmacy, saying they got fibromyalgia. And that really surprises me that we're talking at 2%. And it seems to be a lot of people with irritable bowel and fibromyalgia. It seems like there's a combination there. I can tell you my wife does have it, and all that is true. And she does have irritable bowel, and it is really tough to treat. Here's some of the tender points of pain that we focus on as far as asking the patient, where does it hurt? If they got fibromyalgia, I guarantee you they're going to especially talk about this area up here. I mean, they can't hardly bear to be touched there at all. Transdermal pain combinations can be applied to the tender points of pain. This is just a few, okay? We use ketamine, we use ketoprofen up to 20%. We use gabapentin on about a 3 to 6%. Lidocaine can be used 5 to 10%. Guaifenesin, I get the question a lot, why do you use guaifenesin? As a smooth muscle relaxer. That's what we use that in a topical formulation for. We also use tramadol topically. We use baclofen. We use cyclobenzaprine. Clonidine is a vasodilator for people who have diabetic neuropathy. Try to increase blood flow. That's kind of the top ones. Diabetic neuropathy gels are really, really big for us as well. Dextromethorphan capsules can be beneficial in a 60 to 400 milligram per day divided dose. Can titrate to effect. Sometimes thyroid deficiency can also be linked to fibromyalgia as well. Summary compounding, not limited to choices with drug companies. Compounding offers the flexibility to treat patients with the most appropriate drug and the most appropriate dosage form. Anybody have any questions? Yes, sir.
I have a pregnant patient who's on high-dose tramadol. I don't want her on a narcotic in her pregnancy. Can I wean her with a tramadol patch?
Tramadol gel?
Yeah.
I would say yes. Yes.
So if I told you what her oral dose was, you could create a gel that gives me maybe 10%, 12% less, and over on a weekly or 2-weekly basis, we can keep reducing her drug dose?
Really good chance in that. We may have to add something with it, okay? We may have to do tramadol, and we may have to throw a couple other things at it, depending upon what kind of pain.
Throw all the gabapentin in you want.
Gabapentin does a pretty nice job topically, I'll be honest with you. But we've had some amazing results with those type of things. I mean, yeah.
This would be a fun thing to try.
Yeah. It's definitely doable and triable, that's for sure. Yeah.
We'll try it.
Yeah. Anybody else got any questions?
I'm sorry, I have another question.
Sure.
I do not understand the use of phytoestrogen.
Okay.
It makes sense to me that if you lived in Mexico and you ate yams all the time, that if you stopped eating them, you might want to replace them with phytoestrogen. But most of the people I meet who need estrogen have eat so few vegetables that it doesn't seem to really matter. So I don't understand the use of that as a, quote, bioidentical hormone, when in fact that's really not part of their normal life. Does that make sense?
It does. It does. The chemical structures of those are actually more similar than what you would see with going back to when Premarin was on the market per se, okay? When we look at the drug structure of the two, they're a lot more similar than what I actually wished I would have included the progesterone chemical structure and the medroxyprogesterone acetate chemical structure. You can see a huge difference. But that, to kind of answer the question, they're more chemically similar in structure. And really today, I'll be honest with you, they've kind of went away from saying bioidentical. Now it's typically hormone replacement therapy. Okay, they've kind of went away from that a little bit. But yes, ma'am.
I disagree with one of your very first slides about the goal of HRT to return to natural physiologic levels, because
Yes.
at 55 there shouldn't be much natural physiologic levels. The goal is actually symptom relief.
Yes.
So it's not returning to natural physiologic levels, because they are natural at that time. And
That's true.
bioidenticals
That's true.
should not be interchanged when you're discussing them, because most of the bioidenticals are created, they're not drawn from something.
It's a good point. Very good point. Anybody else? Questions?
Okay, so how can you tell who are the legitimate guys? I mean, clearly we've had in the last year this major international problem with a compounding pharmacy in Massachusetts.
Yeah.
And I hear ads from people that I might respect as a pharmacist, but I don't respect as a marketing man in terms of what he's saying about his pharmaceutical products. Or the way he goes about promoting those products. How can you tell really what's a good compounding pharmacy and what isn't?
Very good question. And I've worked for an independent. I've worked for a chain. Now I'm with a hospital. There's a lot of different organizations out there as far as accrediting bodies. There's one called PCAB, Pharmaceutical Compounding Accreditation Board. What does that really mean? Not much, to be honest with you. Are we PCAB accredited over there? No, we're not. It is a fancy label. I mean, we're Joint Commission accredited. I mean, do I really need to put PCAB on top of that to make me look good? No, we don't. If it sounds too good to be true, it usually is. Okay. Compounding, I will tell you, is a cutthroat business. Okay. Independents look at it as a niche, and I understand it is a niche. In today's world of pharmacy and reimbursements, just like everybody knows, pharmacy reimbursement is dropping. It's dropping day by day by day. And they're looking at niches to get into. And compounding is a pretty good niche. I don't care to tell you. And they will, and I say they, some will do anything to throw another company under the bus or another pharmacy under the bus. So it's really, I think you really have to look at what are they selling. What are they trying to promote? Are they? And one thing I will never do, I will never go out and throw stones about another pharmacy. I just won't do that. They can make up their own minds. I'm just going to present you the facts. You know, I heard this one the other day. Let you know how profitable we might be talking about when it comes to compounding. I was talking to a group the other day, and I was talking about pain management, and we're talking about pain gels, and one of the office attendants says, "Oh, we had somebody." Well, I say we had somebody. We had somebody come off and drop us off some forms the other day from Hollywood, California. Mail order. Okay? Hollywood, California, and Johnson City, Tennessee, to promote pain management.
We are famous.
Oh, yeah. 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 So, you know, I say that to say, you know, kind of, I keep it local and keep it simple and, you know, kind of go from there. But anybody else? Questions? Thank y'all so much. Appreciate it.
So where are your offices?
I am located at the old Wilson Pharmacy
Okay,
building.